So doing primary care and urgent care, I saw a lot of men being turned away from testosterone therapy because of a number. Their numbers were not low enough, so providers didn't want to treat them. These men felt like trash, but they had to walk away with no testosterone because they didn't qualify for it.
I'm Dr. Thomas O'Connor, a lifelong powerlifter, board-certified physician, and published academic author. I've taken care of thousands of men on testosterone and steroids, and now I use my media appearances in this YouTube channel to provide education and harm reduction. Subscribe now so I can help you stay strong and healthy.
Testosterone discrimination. This is going to be a very interesting interview with my guest, Alexia Wallace, who's a nurse practitioner, and she's also one of our testosteronologists. She's from Virginia, and we're showcasing our testosteronologists who have incredible experience and backgrounds working with both men and women in the tier 2 space. But I really wanted to show you guys what Miss Wallace is all about and how she sees this incredible topic, because we know that men are so quiet and they've been discriminated on to get their hormone in this world now of gender affirming care, and even women that have spoke up for their breast health, their rights for themselves, which is all good. It's all good. But what about these men? Remember the Million Man March? I always say, like, where the hell, can you guys come back? Where'd you guys go? All right, Alexia, tell us about yourself, please.
I'm Alexia Wallace. I'm a family nurse practitioner. I've been in the healthcare field for about 15 years. I started with family care and urgent care. And in that time, noticed a gap in men's healthcare, and it all took off from there.
That is awesome. So you've been in your own clinic in Virginia for 3 years?
That's correct. That is
awesome.
Correct.
First of all, tell us, you're a private practitioner. And we know in this world, especially the tier T world, versus the T mills, right? That there is a lot of change going on in that space. And I think we're going to see this. This is not going to go away, right?
That's true.
So let's get right into the topic at hand. These poor guys. Can you tell us about this testosterone discrimination from your perspective?
Absolutely. So doing primary care and urgent care, I saw a lot of men being turned away from testosterone therapy because of a number. Their numbers were not low enough, so providers didn't want to treat them. Their insurance didn't see that their number was appropriate for them to receive testosterone. So these men felt like trash, but they had to walk away with no testosterone because they didn't qualify for it. So in seeing that, I wanted to research and figure out who or what entity was treating men based on how they felt. And that's when my research began. And the most pivotal moment for me was when I had an instance where I felt like crap and I didn't know what it was. Primary care couldn't tell me. Rheumatology couldn't tell me. Even women's health couldn't tell me. So I did my own labs and my testosterone was low. Wow. So the moment that I got my testosterone replaced, everything changed for me. It was like a veil was lifted. I had energy. I could sleep. My libido changed. My husband looked good again. So my conclusion was, if I felt that good as a woman on testosterone, how much better would these men feel if they had their testosterone replaced? And that was when Royalty Men's Health was born.
So this is like we could come out of the closet, kind of, right? It's like, and here you are by my side. So, I could tell you 20 years ago, not to mention 10 years ago, how about 10 minutes ago in some of the doctors around this country, and we don't have to identify where, that the traditional doctors or the good doctors, they look at that number, and it's so cringy and straight up embarrassing for these doctors where the guy's like 257 or he's 259 or 299, you need a 301, that's normal, sir. And it's a young man. Now I'm a data guy, right? That's why you guys, you came to me, right? To thank you so much to work with me because you trusted me, right? I'm a kind of crazy guy, but I like the data. I just like the data. So we know currently today, with the grace of God, this is November of 2024, and the data now traditionally is there that you don't just treat a number.
Absolutely.
But you know, we have been kind of revolutionaries, haven't we?
Absolutely.
Because you had the chutzpah and the ovaries, if you will, right, to come out and to do this for your men. Just tell us more about typical men that see you. What's
Well,
going on?
initially, when men come in, they have an idea that it may be testosterone, but some men have no idea what could be the cause of how they feel. They come in, they have no mood, no motivation to do anything. Energy is in the toilet. They're not sleeping well. Some men don't even mention their sexual symptoms because they have declined over decades. So when they start to get their treatment, after we draw their labs, of course, and see how they look on paper, and they start to get their injections, they're a new person. It's like night and day. They're totally new people. They have energy. They're doing things they haven't done before. They're doing their yards. They're going out with their wives again. They're having morning erections they haven't had in years. The energy is through the roof. So these men are, and I know it before I even redraw their labs because I can see it in them as people. And this is just a direction towards greater health for them, because if they have the energy to work out again in the gym, which they haven't done in years because they haven't had the energy to do it.
Right.
So this is just such an overall improvement because you have energy to work out again. Your cholesterol is better. Your blood pressure is better. It's just a pivotal hormone that just has not been addressed to the fullest.
You know, Arnold said many years ago when, you know, he's kind of unfortunately gone into kind of become a fake for me. And it's sad. And I'm sorry, Arnold, if you're seeing this, because, you know, there's always hell to pay for things that people say and do. But like he said years and years and years ago, you know, steroids, I mean, man, you know, how bad can they be? They make you get off your ass, get off the couch and go to the gym. I mean, now hold on. These are not steroids, but isn't that what you see?
If you think about it, if someone had a thyroid hormone that was abnormal, you wouldn't tell them, hey, well, it didn't meet this criteria, so I can't treat you.
Oh my God.
And that's what is
clinical.
happening. That's what's happening with testosterone. They're saying, because you haven't reached this low number yet, I can't quite treat you yet. Go ahead and get a little worse and then come back to me and we'll fix you.
I
And
always say it's like a woman who comes in and she's on Prozac. This is really very, very accurate, right? I'm a new doctor. Woman comes in on Prozac, right? And it's got dangers. It's got a black box warning, right? Some people can commit suicide. You know, paradoxic suicide ideation.
Right.
If you guys, you can fact check it, right? So, but medicine's complicated. You got to look at the patient. Don't just look at that piece of paper. Look at that patient.
Absolutely.
So if you understand, you're looking at the patient and you're looking at clinical. You're integrating the clinical, and that's where you and I are now. So let me ask you a question. What do you think is, and we don't want to disparage these poor traditional guys, because you and I kind of live like in la la land because we have private practices. I mean, look at you. So the traditional doctors, we kind of feel sorry for them, right? And nurse practice, they're beat up, and you've worked in there. Why do they like this?
A lot of the times, insurance will cause barriers to healthcare. Okay. Because if the insurance doesn't cover a certain thing, our hands are really tied. We really can't provide it. And until a patient knows, hey, I have the freedom to do cash pay and get what I really need. Right. A lot of primary care doctors are doing direct primary care where they're not even accepting insurance because
concierge.
Exactly, because their patients have certain requirements or certain freedoms that they can get with direct primary care. Same for cash pay clinics. If a patient needs certain things, my insurance shouldn't dictate whether I can receive it or not. At whatever dose I can receive it or whatever frequency I can receive it. Because once a month testosterone is not going to be ideal for every single patient. Some patients need once or twice a week.
Right. Let's just talking about that. That's fun, right? Let's talk about some of the real technical sides of giving testosterone to men. You're under our house, for the testosteronologist and our training, and my fundamental pieces, the ABCDs, and you're awesome at that. You're awesome at that. So now let's compare and contrast those T-mills, which we got to come at them. I got to come at the guys. So that's why I did. This is my dream with testosteronology, and then because so many guys, I love what you're doing, Doc. I got all my information. You answered me. You're on the videos. I love it. I just need a caregiver. So took us about 2 years to do. Boom, we open up Testosteronology, and you're one of them, and you're just incredible. And we have women and men. Look at the directory, guys. As of today, we have 20 on the directory, right? 20, and so Alexia is just one of them. And Virginia, because we're being appropriate with the understanding that there's going to be, this is from the Fed in the States, there's going to be brick and mortar requirements and telemedicine. There's going to be both. So, and it's coming down to the provider like you. So you're an affiliate. It's not a franchise. I don't dictate what you do, but I'm looking over you guys and saying, man, you guys are, and we're learning. We work together at least twice a week with our meetings, and we go through clinical cases, and we learn so much from each other. You actually taught me about that auto injector, which I did get, which is unbelievable. So tell us more about the technical side. Let's talk about the heart stuff. Like when you see men run the ABCDs, how do you work that into your practice?
Well, it really has to do with, it goes back to training. Some people who work in T-mills have had appropriate training where they've always looked at the person as a whole, and they've addressed that. So if they go to work in a T-mill, they most likely are still doing that and addressing certain things.
Right.
So when it comes to specializing in testosterone, that's just something that I've always done. And it's so important to know that you have to address those things, because when it comes to testosterone, it comes from cholesterol. So if I'm not addressing your cholesterol, I'm not addressing you as a whole person. It's important to do. And there's so many different things that could be causing your low testosterone. Have you had a head injury? Have you had a history of cocaine use? Have you had an injury with your testicles? All those things are important to document and to question the patient about, to determine what their cause is, so they have an answer to that question. Men want to know. They just don't want you to throw an injection at them.
Well,
so it's important.
Hold on. It seems like men, this is where men get thrown under the bus, right? And I've been around for so long that I could tell you this kind of, again, that like kind of the elephant in the room, that men seem in the medical community not to give a shit about themselves. And
I think it has to do with mainstream medicine, and a lot of men are hesitant to go along with mainstream medicine because they're not listened to, and a lot of their concerns may not be addressed appropriately. So they do have some hesitancy as far as that's concerned, but they absolutely care about their health, especially when it comes down to what's important, when it comes down to their erection and their libido and how they feel when they need to go home to their wife at night or their spouse at night. They care about that.
Now you're a woman. Okay, now let's talk about this. You're a woman. And it's like a brotherhood for me. Guys come in, holy shit, doc. Woo, thank God I'm here. And then we just let the hair down. How about you with these women? Tell us from the beginning, 3 years ago or more, to now, how you feel with the men, because it's got to be, not all women are comfortable doing it.
I absolutely love working with men. It is a preference for me. When I talk to men, it's a level of comfort there. I want to help with what's going on. There's something there that needs to be rectified. And if I could help you get to where you need to be, let's do it. When they come in to get their injections, I'm not handing them off to somebody else. It's usually me that's doing it, because I want to know, what's your progress? Have your morning erections returned? Are you having premature ejaculation? Do you have energy now? Are you sleeping better? I want to know those things, and they're comfortable with telling me that, and they have been from the beginning. So it just has to do with having a non-judgmental approach and an environment that is conducive to them being able to let you know how they're feeling. And if you establish that from the beginning, then it's something that they'll always be comfortable with.
What's the ratio you have, men to women?
95% men.
Tell us about the women. Let's talk about the women for a minute here.
Well, women generally have access to hormone replacement through their fertility clinics or their OBGYN. And of course, they don't have any slack with that. It's not controlled substance to get estrogen. They don't have to sign for it upon delivery. It's, handed out left and right. Menopause is talked about on a national scale, as opposed to andropause. It's a stigma with andropause. You can't get testosterone without signing for it. You have to be on a list. We have to know every single time you get it and where you get it from. It's a controlled substance. So look at the discrimination there. Why is it such a thing? So the women that come to me generally come to me because they cannot be treated for their low testosterone. They're usually told, I'm not a specialist in this area. I only address estrogen and progesterone. So you'll have to find a specialist in order to treat this. I've had women come to me and say, I've had my labs and I've seen it. It's been below 3 for years. And I've just been told they don't handle this. So I have to find somebody that
Right.
does.
So what do you think about so testosterone is a controlled drug, and I know you know why, right? It's not because it's more dangerous than estrogen and progestin. It just isn't. It just
Not at all.
isn't. You know, and now we have something called the Travers trial. Okay, so for all you guys that are interested, and your doctor says dangerous for your heart, which is it is still in the end going to be man for man and controversial to some degree. But if you want to look at, you're in the courtroom, you're in front of the jury and a magistrate. You need evidence. Like you're bringing in evidence. The Travers trial, we never had a prospective double-blinded placebo-run trial before showing. This was just designed to show cardiac danger for men that have had a heart attack and they have low T or they have high risks for heart attack, right? These are not 23-year-old men.
Right.
And then they put them on testosterone, which is interesting. It's gel, not injections. Now we can go down a rabbit hole, and I wish these guys would disclose more of this, because they randomized it. It ran forward, very well done trial for 2 years or more, a little bit more, and there was no difference in the control arm versus the arm that received the testosterone in having another event. That's all
Right.
it's, or having a first event for the high risk guys. That's all it says. Now they have a bunch of secondary issues that I don't think are really even real, like something with acute renal injury and some things. Of course, the red blood cells, they make notes on these things and they're just not sure, which is fine. Those are kind of secondary issues. They're not looking at the primary outcome. So it meant what they thought, or they were happy, I'm assuming, to see. But the problem is all those men that were in the Travers trial, because they already had a heart attack, stent, or bypass, or they're high risk, they were already on medicines for blood pressure, cholesterol, and diabetes. So that's our thing, right? And again, we're not pumping medicines here. I'm teaching these guys, look at man per man fingerprint. And if a guy has a risk for a heart attack, family history, cholesterol, blood pressure, it's not just throw meds down his throat, but really get into that guy and take care of that guy. And that's what I know you're doing.
Right.
And it takes, how much time do you spend with people?
Initial consults, they're there for at least an hour going over what they expect from testosterone, educating about testosterone, because that is so important. And also, too, when they return, to go over their labs and let them know what their labs mean, because all of that contributes to their treatment and what the projection of their treatment looks like.
Right. And how about this? Let's close on this. So we want to hopefully get testosterone off the controlled drug list. Right. I mean, that's going to be good for people. And it's interesting, right? Because testosteronologists like us, like, what is that going to do to us? I've thought it through. And it's like, so could it be good for our business? Well, good for our business is bad for our business. I mean, we're not doing it for business reasons. We're good, right? We're the best. We're the top. So if more people are on testosterone, you're going to get more business because you're a specialist at it, not a T-mill. Okay.
Right.
And an endocrinologist is a great doctor or nurse practitioner, but you can't do in one morning 30 patients, 20 patients, 10 patients, diabetes, problems with osteoporosis. This is diabetes, osteoporosis, adrenal dysfunction, Cushing's disease, thyroid. Let's bring in the guy or the girl with testosterone? No way. And surgeons, this is what I know you guys know, been teaching you guys, and I know you're one of the more advanced because you've been out there working for years, and that's why it's so awesome and easy to take someone like you who's already working in the discipline. Some of the other experts we have want to go into the discipline, and they're not ready. They're not on the directory yet, right? But they're very good people and doctors, and they're taking their time. That's what we're doing. But you're actually live on the directory. You could find Miss Wallace on the directory right now, everyone. So in Virginia. So when it comes to understanding that this is a full day job, right? It's all you do. It's right, isn't that? It's men's health, but you throw a few ladies in, and I know you told me that a lot of the ladies that come in are just the wives of the guys.
They're usually grandfathered in because once you get a man dialed into where they need to be, that libido's up there, and you got to get that woman to where they need to be to keep up.
That's a problem.
Not once you get everybody on the same level. It's a good problem to have.
This, life is, don't you love that we're here today together and we're open for the public to see us together here. So, all right, the last piece is the primary care docs and the nurse practitioners. There's not many doctors left in primary care. The workforce in primary care is nurse practitioners. Mm-hmm. You know that, mm-hmm. or physician's assistants. I think they're more in the surgical world. So NPs, right? Other doctors, other nurse practitioners. How do you work with them? Tell us about that.
As far as if a patient needs something that maybe is not specialized as far as testosterone, some people have to be referred out. They need to go to endocrinology if they have something, or urology, and they have to be referred to that source. And we do that several times.
Right. Mm-hmm. So that's the thing that I think a big difference in the training group that we have here with you guys is that you guys know you're a specialist in testosteronology. That's a full day job. You can't really do anything else. That's a full focus job. However, apart from, and the differences in the complaints and the danger we see out there from the other clinics that are just moving too fast and not specialized, is that they don't work with primary care. They don't work with cardiology doctors. Now, the hematology, you're not going to get me going on the hematology and the D for deposition disease because that's just so complex. Mm-hmm. But you guys are really understand when the red blood cells go up, you're not just looking at the CBC and dumping blood. Mm-hmm. That's just really, it's just embarrassing mm-hmm. that those clinics do that without understanding the condition called androgen-induced erythrocytosis. It's not polycythemia vera. Doctors, it's really embarrassing. It's even embarrassing for hematology doctors. Stop testosterone. They really don't even look at the man that he's been on it for years and his red blood cells and his RBC count. And when you look at the whole cumulative picture for the man with his history of with or without strokes or DVTs, pulmonary embolism, the whole genetic profile, mm-hmm. and you look at the iron studies, I've been working around this for 20 years. Rarely, there are some men that have hereditary hemochromatosis, or if they may have some thalassemic traits mm-hmm. that are more than traits, right? That's fascinating. Right. And I see it, I stand and I refer to hematology, urology, correct, cardio. That takes so much damn time, mm-hmm. but you have to do it.
You have to.
Right, and that's why with the grace of God, you're not going to hurt people. When so many guys have come to me, and now it's you guys, I'm trading off, scaling out to you guys. It's like so many have come to me, so many, almost like a 90 percentile ranking where I've been through this mill and that mill. Maybe the wife comes in kind of with the guy, right? And you're looking at the wife the whole time, like, shut up, idiot. We're talking about, it's kind of like, whoa, it's not even an old guy. He's like, all right, guys, I'm sitting right here, but don't worry about me. No, you ended up in the ER. Your doctor looked at your red blood cells and said, what the hell is going on? You can't have that disparity between healthcare providers. That's why you're so good. Mm-hmm. It takes time and effort. And when you say something, I know you're like me, you don't know something, I don't know this, refer it.
Absolutely.
Get the answer.
Absolutely.
This is old school, just healthcare training. When you're in the hospitals, you're in the clinics from the training years through the residency, through all these, even even at my age, where I am now with my experience, if you smell something you're not sure of, that's an incredible decision-making mm-hmm. tree, right? You could go one way and just wing it and hope for the best, will bite you in the ass. Mm-hmm. 1 out of 1,000, or less or more, or you go the right way and you say, I got to do it. I'm not sure what this is. I got to be confident about that mm-hmm. to the patient, but I'm going to say, let's help you refer to an expert specialist in blood issues or endocrinology. I see a lot of diabetics that are mm-hmm. complicated, real diabetics, even type 1, with A1Cs super high. And
Mhm.
I have to say, blow the whistle. Wait a minute. Let's see if we can get, and it takes 6 months for them to see the damn specialist.
Mhm.
And then it's like 100% of the time, it was worth it. And the patient's like, Doc, I appreciate that.
Right.
That you made me, I was, I don't know. I don't know, So this is so great. Anything you want to close with for all the guys out there that are discriminated on for not getting their own hormone?
Just don't give up. You know how your body feels. Find somebody that listens to you and move forward, because it's night and day once you have everything optimized. It really is. Just don't give up on yourself.
How can the viewers, we're going to put up the B-roll again for you, contact you? Best place.
They can find me at royaltymenshealth.com.
Awesome. And at testosteronology.com, you could look at become a provider, find a provider, boom, find a provider. And she's on that. The list is scrolling, and it is slowly, steadily getting bigger and bigger. But thank you so much.
Thank
This has
you.
been absolutely wild. And give us a lot of cool comments, guys. Thank you so much.